Hey there Internet, my name's Luxander, and today we are going to be talking about bottom surgery. Specifically, as a transmasculine person, I'm going to be talking about those kinds of surgeries. We're not talking about the kind of surgeries that trans women would usually be getting. Frankly, that is super out of my wheelhouse. I solicited some questions from the community tab here on the YouTube channel and also on my Patreon, so I will try to address some of the questions that you all had in the course of making this video. Typically, when we're talking about bottom surgery, we are talking about the creation of a phallus. I do want to note before I get really into it though, that some people will get a hysterectomy and say, like, that was my bottom surgery. I know Skylar Kurgel, who used to at least make videos on YouTube. I don't know if he still does, but he is a trans man who had a hysterectomy and considers that to be like, that's bottom surgery. That's it. More broadly though, this does typically refer to a series of surgeries that end in a result that is supposed to be a pebis. We play fun games with the algorithm. I do want to add a couple of things, just a bit of information about hysterectomies. You don't necessarily have to have everything removed. Typically there are like 3 components to a total hysterectomy or a full hysterectomy, and that's the removal of your uterus, cervix, and fallopian tubes and ovaries. You can choose to keep one or both of your ovaries just in case you don't plan on staying on hormones forever, or if you're concerned about at any point losing access to your hormones, because you have to have either estrogen or testosterone in your body going any length of time without significant enough numbers of those hormones will cause bone damage. Basically, it will cause osteoporosis. This is why hip breaking in menopausal women is so common, and some people also choose to keep their cervix for sensation reasons. But yeah, I just wanted to add that before we get too in-depth on the other aspects of bottom surgery, just so people know that there's not a one-size-fits-all for literally any aspect of this. Very broadly speaking, there are 2 approaches to bottom surgery for trans men, transmasculine people. Essentially, with these 2 different approaches, you have one method that uses your natural growth from testosterone, and you have another method that uses a skin graft from somewhere else on your body to create the pillar. The first method is called Metoidioplasty. Jamie Rains, Jammy Dodger here on YouTube, has a series of videos about his bottom surgery journey. If you want like details about how that process works, I will just broadly say that when you are on testosterone, your natural bits down there tend to get larger. Most people experience some amount of growth of their glands tissue, and with metoidioplasty, it is that which is used to create the pebis. Metoidioplasty is usually shortened to meta, which is how I will refer to it for the rest of the video. There are a number of different stages that can go into this, and there isn't necessarily a one-size-fits-all objective to the end of these procedures. Starting with the basics, I guess, there is a procedure that is colloquially called simple meta, which is basically they go in and release the ligaments, I believe, that are holding your stuff down, and it makes it able to spring up, and they take some of the tissue surrounding underneath here and like wrap it so that you essentially have a little micropebis. And with simple meta, that's just what it is. Everything else is left the same. There are also options with both metoidioplasty and phalloplasty to have scrotoplasty, which is the creation of a scrotum and later putting in implants. You can also have urethral lengthening so that you can pee while you're standing up. With meta, this is usually only doable really if your natural growth is able to clear your fly, is how it's put in the community. Basically, if it's big enough to stick out, you could still hypothetically have urethral lengthening. Otherwise, you just wouldn't necessarily be able to do it super easily, like not be able to stand to pee very easily. Many people also choose to have a vaginectomy, which is basically they close up the original hole there and put it away forever. You can only do that if you've had, I believe if you've had a total hysterectomy, which is the removal of the uterus, the ovaries, and the cervix, because otherwise things up there could become cancerous, and you really, really don't want that, and especially not be able to check on those things with pap smears. You can also choose not to have a vaginectomy and sort of have, a little bit of both, when you get done with all your procedures and everything. However, doing urethral lengthening is pretty much not done if you don't also have a vaginectomy, because the complication rate for urethral lengthening, or UL, is pretty high anyway, depending on various circumstances, but it's a pretty high complication rate aspect of the procedures. So apparently the complication rate is so high if you don't also have vaginectomy that most surgeons will not do it. So with metoidioplasty, there are a number of different surgical end results you could end up with depending on what you want. You can do simple meta, which is just the ligament release. You could have urethral lengthening, scrotoplasty, and implants, and you could do vaginectomy depending on the circumstances. These two types of surgeries, meta and Phallo, both have multiple stages. So I will say about meta, as far as I understand, typically with meta, they will do, in the first stage, creation of the phallus and maybe creation of the scrotum. I think they may also take the first steps towards UL, especially if you are having vaginectomy at that same time. It really depends on where you live and what the surgeon wants to do in your particular case, or some surgeons have like a pattern that they typically go with. This is a process that requires like a ton of research and looking at people's results and talking to people who have been patients of various surgeons to find out more about them and what they will typically want to do. But yeah, you could potentially have the creation of the phallus and scrotoplasty in one stage, and then the implants, silicone implants usually, in the next stage, and urethral lengthening can sometimes be a multi-step process. Some of the perks about going with meta are that you are able to attain natural erections, in the sense that you become interested and blood flow happens and it can perk up by itself. Another big perk is that it doesn't require any skin grafts from elsewhere on your body, so you will not end up with any other visible scarring. One of the mixed pros and cons is that it can depend on whether you are able to stand to pee, size-wise, and all that jazz. One of the big cons about meta is that you do end up with a micropubis. It's not going to be something that has a very noticeable bulge, and for some people, this does not do enough to alleviate dysphoria, or they don't feel that they are as capable of doing penetration as they would like. So it's not entirely uncommon for people to have meta and then later go on to have phalloplasty on top of that, which, I mean, I don't know, it's kind of cool. You end up with two pubis. More pubis. Now moving forward to talk about phalloplasty. This is the other major surgery type for trans guys. As I said towards the beginning of the video, phalloplasty is a procedure which uses a donor site from somewhere else on your body to create the phallus, and then you usually have, so that's usually a full thickness graft to cover that place. You will then have a split thickness graft, and then they put that in on top of where your main donor site is. There are multiple different donor sites that you could choose from. The one that I see most commonly right now is radial forearm flap phalloplasty, which takes a skin graft from your arm. They usually want to go with your non-dominant arm because you can have issues with mobility and grip strength while you're recovering. This one is popular because there are two nerves basically that run up your arm that can be taken so that you have the optimal chance for sensation as far as both tactile and erogenous sensation. From what I understand, some of the other donor sites don't necessarily have that that nerve for erogenous sensation, so you would be able to feel the touch, but it wouldn't necessarily be super arousing. Some other donor sites that can be used are the thigh. I believe that one is called ALT, A-L-T, phalloplasty. There's also MLD, which I think uses skin off of your back, and there's also abdominal flap phalloplasty, which takes some skin like off of your lower belly area. Aside from the likelihood of having erogenous sensation, all of these different sites are sort of, your mileage may vary, it's up to your preference sort of deal. I have seen discussion from some people who've had non-forearm phalloplasty who do have erogenous sensation in their pubis. All of these things, again, they vary a lot, and you'll definitely need to shop around and talk to surgeons about this, because holy shit, there's so much variation. Typically, along with phalloplasty, you will also find most people doing scrotoplasty with implants. Vaginectomy is also very common, and to just a side note, you in this instance, burying your original junk, your original glands, is optional. I am aware of some people who have full, like, phalloplasty results, and then sort of tucked behind it is just their original junk. In that specific instance, it doesn't necessarily look exactly the same as it originally did, because the lips majora are used to create the scrotum. So again, with phalloplasty, there are so many different options for what you will end up with at the end. Basically all the same info about urethral lengthening and vaginectomy. With phalloplasty, because it is a skin graft from elsewhere on your body, there is blood flow, but it does not become engorged as you would typically assume. So for erectile function, there are broadly two different types of device, basically, that you can get implanted to have that function. I think the more common one is the inflatable rod implant, which is, I think it is filled with air. There is a reservoir of air that is put, I believe, under the skin of your abdomen. There is a pump device, which typically takes the place of one of the testes. The other one would just be a silicone one, and it inflates with air. So in this option, you can either have a state where you're flaccid and then get hard. You can do both of those things. The other broad type is a semi-rigid rod implant, which is like, essentially the way that it looks is just like a series. This is the common one that I have seen. I know that there are also other flexible ones, but the one that I have seen most often is, it's like a series of small balls, and they it can like move and be positioned in different ways. So you could have it pushed down and holding this shape if you want it just to be against your body, and then you just kind of like put it up when you want to use it. So these are kind of broadly the options. I do want to say with the semi-rigid rod that a couple people who I've talked to about it have said that it does not, in fact, seem like they have a constant boner, if that is a concern that you have. Another thing to note about Phallo is that whatever size you have is what size you have. As I said, it does not become engorged. You can either have it be flaccid or hard, but whatever size is there is what's going to be in your pants all the time. So if you're someone who, really wishes that they had like 7 inches, be aware that that's going to be 7 inches in your pants at all times. That's going to be there at the swimming pool. It's going to be there at the massage therapist. There's no putting it away once it's there. So that is just something to be aware of. I know plenty of people have ended up with like 4.5 to 5 inches, which seems like kind of small for sexual function, but it is manageable for them because it's there all the time. I think I may have gotten sidetracked a few minutes ago trying to talk about burial. So when you're having phalloplasty, your original little junk back there, sometimes people will have it buried, so they'll take that little thing and like just cover it up. Most of the time, from what I understand, it can still be stimulated with pressure. So if you were to go for an option that has less likelihood for erogenous sensation on your phalloplasty, a lot of the time, from what I understand, people can still achieve, climax or whatever by stimulating that down there, even if it is buried. Leaving it unburied, obviously, you would basically have whatever original sensation that you currently do. Phalloplasty is also done in multiple stages. Typically, the first stage will just be skin graft, creation of the phallus, skin graft to cover this over here, possibly also vaginectomy. It depends, again, on what your surgeon is willing to do. All of these things at the same time can be somewhat stressful on your body, so this is done in multiple stages to try to ensure that you have the highest probability for good healing as possible. I think that typically glandsplasty is done later, like a second stage, and then I think typically a stage 2 or 3, depending on how those previous steps were separated out will be additional urethral lengthening and implants of both the testes and the erectile device. So, pros and cons of phalloplasty. Phallo will give you a good-sized bulge in your pants, nice penetrative length, generally tactile sensation, if not erogenous sensation. You can have scrotoplasty. You can get urethral lengthening so you can stand to pee. You can leave your original T-peen available or bury it. And of course, vaginectomy, depending on whether you want to have urethral lengthening as well. Cons for phalloplasty would include that you will definitely have a scar somewhere else on your body. It will be a pretty sizable scar. For a lot of things that I've seen with the radial forearm flap, it's you know, most of the way around your arm, and whatever the length of your Venus is how long your scar is going to be. That's a big reason why some people will take the risk of not getting erogenous sensation by going with a non-visible donor site. One of the other cons, I would say, is that urethral lengthening, I believe, has a higher rate of complication with Phallo than with Meta. And often, one of the big reasons for that, especially in one of the Phallo providers in Canada, is that if you don't do sufficient electrolysis on your donor site, so like we all have arm hair for the most part, most people, and part of the forearm here is used to construct the new urethra. And if you have incomplete electrolysis results, if there is still hair growing in there, it can cause big issues if it's inside your urethra. Aaron and Sweeney recently did a bottom surgery Q&A where he was talking about this. One of my community members here on YouTube asked on the post if urethral lengthening was easier with one or the other. So that aspect of having hair from your donor site is one thing that I think would make it more difficult with Phallo. And also, from what I understand, it's a length issue. I think that with Meta, you have a shorter distance to cover from the original urethra to the tip of the new one, and with Phallo, I have seen some people ending up with multiple stages where, okay, so they've had their vaginectomy, now their pee is coming out like right behind their scrotum, or from their scrotum, or from halfway up the shaft, and you have to do sometimes multiple stages of urethral building to get it to where the ideal goal typically is at the head of the glands. So for those reasons, I would say it probably is a little bit easier to do with metoidioplasty. This is the most common form of complication, by the way, with either of these surgeries, from what I understand. The most common form of complication is through urethral lengthening. Things like necrosis are usually not as common. There's also a really big risk of infection when you have an implant put in, so there's a lot of precautions taken regarding antibiotics at that stage. Ooh, okay, this is a really good question that someone put on the community post. They asked whether you become infertile after bottom surgery. As with everything else in this, the answer is it depends. If you have a hysterectomy, obviously that's it. Done. You are infertile now. If you were to not have a hysterectomy and get like a simple meta, you would still likely be able to have children naturally. Once you get into more complex forms of the surgery, though, it is generally not considered wise to, even if you do maintain your fertility, to attempt a natural childbirth, because you're changing things down there in a way that if you were to attempt to, pass a baby through that area, it would pull, stretch, possibly tear things that are your very expensive surgical results that you don't want to damage. However, I don't personally see why you couldn't go ahead and have a baby through a C-section. I personally think that C-sections are like the absolute last resort. I don't think that that's something that I would want to do unless it were like a serious emergency situation. But I don't see why you couldn't do that, honestly. Up to you. Oh, another thing I want to say about implants is that typically they do need to be replaced eventually. The inflatable rod has a mechanical component which can break over time. I'm not totally sure why the semi-rigid rod needs to be replaced after about 10 years, but after about 10 years, you will need to have it replaced. And for some people, it depends on how intensely you scar, but you might only have like 1 or 2 replacement opportunities before the scar tissue makes it basically impossible. But I think the longevity, like how long you have to go in between those replacements, would sort of depend on the how vigorous you use it. That was a whole lot of info, and as your reward, I'm now going to get to my interests and hypothetical ideal desires for what I would want from bottom surgery. I mentioned this in my top surgery video recently, where I was saying I don't feel the need to get top surgery at this point because my social dysphoria is greater than my body dysphoria. And I mentioned in there that I am thinking about bottom surgery, so here you go. I would say that this is not a social dysphoria issue for me at all. It's also not really a dysphoria issue in general for me, because I don't feel particularly bad about what I presently have, and I don't even really feel particularly bad about what I don't have, but I am over the moon enthusiastic about the idea of a thing that I could have. So for me, this is very much a gender euphoria thing if I were to pursue it at some time in the future. I have in the past worn a packer to attempt to address, people doing bulge checks on you, but I don't want bottom surgery because of that at all. I can just wear a packer. It does not bother me. It doesn't cause me any dysphoria to wear a packer. I know for some people it can just be like a reminder of what they don't have to wear a packer, but I don't have this issue at all. And if I'm too annoyed with the sticky plastic of the packer, I'll just shove some socks down there. This is not a particular issue for me. I am married and monogamous and have been for a while, like a long time, so there's not an aspect for me where I'm feeling the need to, fulfill the expectations of a sexual partner. This is something I've kind of only recently acknowledged that I do want. I have a really difficult time wanting things, especially things that are expensive. I grew up poor, so it's tough for me to recognize, I think about this a lot. I do want this. I have discussed with my partner the idea of me getting a gender-affirming hysterectomy at some point. I have extremely bad cramps, and not while I'm on testosterone usually, but if I were to stop T and have a normal hormonal cycle, what is up with my eye? If I were to have a normal hormonal cycle again, it would be extremely painful. It sucks. And it's very irregular. I suspect that I have PCOS. So I've thought about that before, potentially getting an affirming hysterectomy. I would probably not remove my ovaries, or at least not both of them. And I think that I would probably try to advocate to keep my cervix. Most people, most surgeons, when they're doing a hysterectomy, also remove the cervix, but for sensation reasons, I would want to keep mine. I'm also just really not sure if that's a necessary thing for me. I don't know that I need a hysterectomy for gender-affirming reasons, and I am not decided yet on whether carrying a child is a thing that I would want to do. Life is complicated. Basically, I'm a lot less concerned about the future possibilities of a hysto than I am about possibly pursuing additions. I am much more interested in phalloplasty than I am in metoidioplasty, personally, for me, because, again, I don't have any qualm with my junk as is. I'm pretty pleased with the changes that have occurred from having been on testosterone for however long it's been now. It's 3 years. I've been on T for 3 years, and I'm pretty happy with my growth. I don't think that my growth is significant enough to be big enough. This is the main crux issue, as far as I can tell, between Meta and Phallo, is the size thing. Not only do I basically just don't want to change anything that's currently there. I just want to have something added to it. So I'm very interested in phalloplasty because, I mean, honestly, for me, it's like mostly erotic. I don't care so much about standing to pee. As I mentioned, if I were not to have vaginectomy, it would be nearly impossible to have urethral lengthening done. Basically, I don't want to have vaginectomy. I don't want to have scrotoplasty or implants in that way. I don't want to have my original junk buried. I want to leave all of that as much as I can exactly the way that it is, and the only change to that being an under-the-skin nerve hookup, which really wouldn't drastically affect the form or function of anything that I already was born with or whatever. I am most interested in radial forearm flap phalloplasty because, again, this is mostly a sex thing. So I want to have the highest probability to have good erotic sensation as well as tactile sensation. And since I don't want to have scrotoplasty, I think that completely rules out the inflatable rod as an option for me in terms of having an erectile implant. So I'm basically limited to the semi-rigid rod, which I have no problems with. Again, from the people that I've seen talking about this, it's not super difficult for them to put their junk away in such a way that it doesn't seem like they have a mega boner. But yeah, and I don't really have a particular size objective. I would be content with telling my surgeon, like, whatever is going to be proportional to my body, go ahead and do with that. I am not trying to impress anyone. Just to clarify, a couple people asked, what about this is something that you want? Like, are there external pressures about this in the way that there are external pressures about top surgery? And for me, there's not. Maybe there would be if I were dating more, but I'm not, and I'm not really concerned about a feeling of completion about I'm a man now because I have a pubis. That's not part of it at all. It's really just hot. I think that's part of why I am also willing to accept it as something that is not going to happen for years if it does happen, and is something that I could potentially not ever do. I don't think that my life would be any worse if I just didn't. It's just that I am recognizing that it's something that I think about, and that if I am allowing myself to be honest with myself, I want that. I want it. This could maybe have gone earlier in the video, but one of the main reasons why I'm personally willing to accept that it's going to be a ways off is that I want to do scar aftercare type things that may not end up being covered by insurance. If I even go through insurance to do this, I am not a trans man, so I don't know if it will be covered. One of the things that I have primary concern about is the visible scarring. I am really uncomfortable with people asking me personal questions. I have a new rule that if a cis person asks me, like, can I ask you a personal question? The answer is no, because it is never going to turn out well for me. The answer is no thank you to that. But this is something that concerns me a lot. So because of the fact that with phalloplasty, they take a full thickness graft from here and only a split thickness graft from your thigh to replace it, you don't have any fat here anymore. So for many people, there's an indent in their arm where not only do they have a visible scar that is a different color than the rest of their skin there, but it has an indentation and like sometimes a pretty drastic difference in the circumference of their arm. And from what I understand, you can have, I believe it's called Integra. It's like inserting stuff in there to make it more similar to the way that it was originally. I think it's to replace the fatty layer, basically. And there are also a number of things you can do as far as scar care and physical therapy to retain your full range of motion and to lighten the scars over time so that you could potentially end up with, like, oh, I can see that there's scarring there, but it's not jumping out at you. Like, it's particularly important to keep the scar out of the sun if ever possible. If you know anything about top surgery, you will know that it's typically recommended, at least in the first year or two, to not expose your scars directly to sunlight because it will make them get a whole lot darker. So yeah, basically my ideal setup. This is since I was like age 13, before I knew I was trans, I was thinking like, wow, you know it would be really cool to just have a pubis in addition to everything that I already have. And then I learned that that was a real tangible thing that could physically exist in the world, and for a while I did not know what to think about that. It was a strange thing to adjust to, but now I have basically come around to realizing that, like, oh, it's okay to want things, and it would be gender affirming, I guess, in that that's just how I envision my body ought to be. I don't know how to describe this. Again, it's not a dysphoria thing for the most part. I do have bottom dysphoria at times, let me be clear. There are definitely times where I'm like, wow, it really sucks that I don't have this. But for the most part, it is a pursuing of something that I know would be fucking awesome. Like, it would just be awesome. I would be so deeply pleased if I were able to go through this and have this end result. I mean, it's kind of scary, honestly, to have to go through multiple stages of surgery. I would likely have at least 2 stages. There would at least be the skin grafts, creation of the phallus, and the implant later on. It would depend on whether glandsplasty was in the first stage or if it could be done later. So it might end up being 3 stages, each having like 6 to 8 weeks of initial intensive recovery, and not to mention additional aftercare for the scars on the arm. I'm not so concerned about the scar that will end up being on the leg. That doesn't bother me so much, but I am very bothered by the idea of having a gigantic scar. So again, this is something that I don't even know if I'm going to do. I am only just now about to have a job after not having one since I quit to be a student in August of last year. This is all just kind of me having thought about this for like 2.5 years now, and finally being willing to accept it and enough to talk about it publicly, I guess. So, don't be a jerk about it. I have been recording for over an hour, so I'm going to go ahead and say that that's all from me today. If you liked the video, please give me pretty analytics to look at and comments to read. You can find me on Patreon and PayPal just in case I was not careful enough about the algorithm. Tip me, please. You can ring the bell for notifications of when I upload, subscribe if you would like to, and I really hope that you have an okay day. Bye. Thank you to all of my patrons for your patience and for your support in this month of October, especially since I'm pretty sure this video is not going to be good for the algorithm. Anyway, I want to say thank you to Sean, Tina M, Bisexual Disaster, R. Halverson, Frozen Summers, Michelle Winter, Sarah A, Suzanne Maynard, Wellington Marcus, Amanda B, Athiette, Elizabeth Bartell, Eileen McCall, Mr. Atheist, and Rosa Bovett showing up.